Okay, so good morning, everyone, or good afternoon. My name is Dory Horn from the New England QIN-QIO, and I will be your moderator for today's webinar, Updates on Flu, Pneumonia, and Shingles Immunizations for the 2018-2019 season. Thank you for joining us for today's webinar. Before we get started, I'm just going to go through a few housekeeping items. This call will be recorded for training purposes. I will provide you with the details on accessing the recording at the end of this webinar. The phone lines will be on mute for the duration of the presentation. We will address questions at the end of the presentation, but you can go ahead and ask them in the bottom right-hand chat box throughout. I will provide you with instructions on how to ask a question over the phone at the conclusion of the webinar if anyone has any questions. Please make sure to send all of your questions to all attendees. I have put the presentation link in the chat box, and I will go ahead and do that again if you would like to access the presentation. And at this time, I'd like to turn it over to Russ, who will introduce our speaker.
Good afternoon, everyone. Sorry for the technical difficulties. It's my pleasure to introduce today's speaker, Dr. Chris Campanile. Dr. Campanile is a family practice physician at Coastal Hillside Family Medicine. He's a clinical coordinator at Health Centric Advisors, a clinical associate professor in the Department of Family Medicine at Brown University's Warren Alfred Medical School. The floor is yours, Dr. Campanile.
Great. Thanks very much, Russ. And sorry for the delay there. I thought the only delay I'd have today was getting to work because, at least around here, the school buses are starting to run again. But I'll try to go quickly so there is time for questions at the end here. I don't have anything to report in the way of conflict of interest. Our objectives, broadly stated, are just to go over current trends in vaccinations for influenza, shingles, and pneumococcal infections, understanding the scheduling for the two pneumococcal vaccines, and most importantly in my mind, if you take nothing else away from this, is some ideas about how we can innovate to improve our vaccination rates. So listing here are benefits of vaccines, which are things that most people know and I hope believe in. More importantly for me, these are talking points for patients who need to be convinced to accept a vaccine. Our responsibilities, I think, first is to educate ourselves and to know when vaccines ought to be given, educating our patients about the benefits of them. Being a really strong advocate, talking like someone who really believes in it and someone who can show them a Band-Aid on your arm that you already received the vaccine, knowing when you shouldn't give the vaccine, and again, knowing the schedule to give them, and knowing how to report adverse events. At the end, there is a resource list, and one of them is the VAERS website where you can online report an adverse event through a vaccine. And so we'll start with influenza with the sick puppy here. Here's some data from Healthy People 2020, and it runs through several years of vaccine rates, 2011, 14, and 16. And the first row is for adults 65 and older, and you can see it runs around 65%. The goal for all of these categories is 90% for 2020 Healthy People. The high-risk adults, those with immune-compromised systems or with chronic illness, run a little lower, and then healthcare personnel run anywhere from the 65-year-olds to a little bit higher. I think the hospital is a little more intense about enforcing this. Long-term care, maybe a little bit. I think in Rhode Island, at least, luckily there is a regulation that if you are not vaccinated by December 1st, you must wear a mask, and I think that maybe cajole some people because they don't want to be seen as someone walking around with a mask who refused to be vaccinated, but that might be the reason. So here is a slide that is showing some data from the CDC, and I don't think there's an infection that is more widely tracked and monitored and have data collected about it than there is for influenza. So this, and at the bottom of this, you can see a website with the flash description of receiving these weekly updates. I get these every week throughout the flu season, and it's very helpful it shows the surveillance of influenza-like illness that's reported. There are sentinel centers around the U.S. and around the world that do this kind of reporting about flu and what kind of flu is being seen. And you can see for 2017 and 18, it started as early as any season, ended as late as any season, and actually, if you look at the volume, or what you might call the area under the curve, it actually is the sum total of a couple of pretty decent in severity flu seasons. So this is the kind of graph that I will pull up on my computer and show people and say, listen, this was no laughing matter last season. It was a very prominent season for flu. The weeks at the bottom start with the first week of the year, so week 1 is January 1st, and you can see that the flu usually starts around week 48, around December, and it can go out to week 16, out to April in a long season like that. I would also say that, so here's some other data that shows hospitalization rates for the flu. And again, 2017-18 really stands out. And showing this and then annotating it with some information, like this was the worst flu season in 6 years. It was a flu season where there was a widespread, what's described as an outbreak in all 48 continental states. There were almost 200 children that were killed by the flu and its complications. So you can really make a very dramatic case for people who really don't think that they need the flu vaccine. So here's a picture for people that like a microscopic view of both the flu vaccine and the pneumococcal bacteria here. The flu vaccine, looking at it like this, you can see the antigens on the outside, those proteins and glucose-like molecules that will stimulate antibodies. And you probably know that last year, in the last 2 years, the subtypes for the flu vaccine has been H1N1 and H3N2. So the H is the hemagglutinin and the N is the neuraminidase chemical items on the surface of it, and that's really what we follow and what is the basis for creating the flu vaccine each year as they monitor information around the world. It also is a virus that has what you call antigenic drift, so those N's and H's can actually change in character to become different H1, H2, H3, etc. for N. So it makes it difficult to have a standard vaccine that you know is going to be effective for year after year. Complications for the flu, no surprise to anyone here listening, I'm sure the older you get, the more likely you are to have complications. There's a different vaccine for 65-year-olds and older. I'm sure there are people on the call today who are staff representing long-term care facilities, certainly a high-risk condition there, and other people with cardiac, pulmonary, metabolic, kidney, and other immune deficiencies. Pregnant women, certainly all pregnant women should receive the flu vaccine, and some indigenous populations, the American Indians and Alaskan Natives, and children who are less than school age and less than 2 years old. This is not really a cartoon I put in here because I don't want to make this more complicated than it is, but I think we can try to make it as simple as possible. There are a number of different vaccine types that are available. I'm not sure about where you are, but here in Rhode Island, there is a certain set of vaccines that are supplied by the state where we buy the majority of, for my practice, our vaccines. We have a pediatric quadrivalent vaccines and an adult quadrivalent, and then we have a high dose for 65 years and older, which is a trivalent. And there is the high dose for 65 years and older, which has about a 4-time concentration of the virus antigen in it. And then there's the recombinant, the RIV formulation, which is especially helpful for people that have egg allergies. There has been a change this year in what the CDC has put out. In 2015, they had a bulletin that really discouraged the use of the live attenuated nasal vaccine. Looking at the data, it was not as effective in those who were vaccinated, which was mostly the pediatric population. They revisited that and put out information the spring of this year and said, and as it reads here, that any licensed vaccine, whether it is the standard inactivated flu vaccine, the recombinant, or the live attenuated nasal flu, is fair game for giving the vaccine. There is a number of people who should not receive the nasal vaccine, children younger than 2, people over than 50, pregnant women, pediatric population receiving aspirin, children 2 to 4 who have asthma, people taking antiviral drugs within the last couple of days, and people who care for severely immunocompromised patients because they can be shedding the virus for some 7 days after that. And here's the indications for the flu vaccine, much of which we have gone over already. You really need to think of 6 months and older for administering the flu vaccine, and using the recombinant vaccine for people that have an egg allergy, and using the high-dose vaccine for people that are 65 years and older. The efficacy of the flu vaccine varies according to how well the match was and how much immunity you might have from previous years, your age, and overall health. So a good match, and this list here is 60 to 75% effective, I would say is a very good match. There is good data that shows that there has been significant reduction in hospitalizations for older people and in death from the flu from older people. The data from CDC from last year showed that if you receive the flu vaccine, you had a 40% decrease in risk for having an office visit for a flu-like syndrome. It decreased your chances of getting the flu depending on what kind of serotype it was. For H3N2, it's 25% decrease in risk. For the H1N1, which was the more predominant one, it was 65% effective in preventing you from getting the flu. And the type B flu, which is a little less common but shows up sometimes later in the year, there was about a 50% chance. So. And here's a slide that has to do with egg allergies. If someone really doesn't have any kind of allergy to cooked eggs, you really can follow the usual protocol. If someone has hives with eggs and they're 18 through 49, they qualify for the recombinant vaccine. If they are older, you can, if you would like, give the regular inactivated vaccine and insert them. It depends on your comfort level for that. I mean, I would want to have certainly some Benadryl and probably an EpiPen around if something more than hives happened. And if someone has a serious anaphylactic reaction to the flu, then that is not something that anyone but an allergist with the right setup should be administering. This depiction, I think, is helpful for explaining to people, maybe to patients, it's a good picture to show the flu vaccine, the flu virus, I should say, is inhaled, and as you'd expect, it resides in the upper and lower respiratory system. And so it produces those symptoms that you would expect, which would be a cough and a runny nose. But cytokines are these inflammatory mediators that are really the host, the patient's response to infection, much like a fever is. And they are responsible for the more systemic systems, which are muscle aches, and really feeling knocked out, that malaise and the fever. And this also really distinguishes, and you can explain to people why you might think they have the flu or don't have the flu, because this is not the kind of picture someone with a routine upper respiratory infection, which I'm starting to see already, and we'll see a lot this week because school is back, from the real influenza infection. Again, here's some more data. This is looking at hospitalizations from the flu, and it looks in the last year, and it went through week 17, and it really shows you, and it compares it with the year before. The lavender color is the previous season, and the greenish is the most immediate past season. So there was, in the younger group, 50 to 64, and then in the 65 plus, quite a bit more hospitalizations from the flu. So I think we've already covered a lot. We really need to respect the ability of the influenza virus to create bothersome illness and serious illness and death. The CDC, as part of being on that weekly email, I received some emails because this is the 100th year of the most serious influenza Spanish flu epidemic of 1918, and they really put things in perspective looking back on that. Adverse effects from the flu vaccine, which is worth going over with people, especially if they are reticent to receive it. The majority is really local site reactions. People may have a little bit of a systemic, as listed here, malaise, fever, chills, myalgia. I explain that to people when they say, I got the flu from the vaccine. I say that this is really what you should think of as the body producing its immune reaction to the antigen that was in the vaccine. It is possible, not likely, but coincidentally it could be possible that someone was coming down with the flu and they really do have an influenza-like illness. Allergic reactions are rare. Guillain-Barré, very rare, more associated with the 1976 swine flu, as some people may remember. And finally, at the bottom, the real project in the season is combating what I really consider baseless, sort of community-based rumors, at least in my community, that I see. I see lots of different people. I see lots of ethnic populations where I live. And there are some hard and fast ideas that seem to get spread and more deeply rooted than what I can tell people in the exam room. So I think it's important from as many fronts to try and debunk that kind of thinking. And this is just, again, revisiting knowing just how to report an adverse event and the fact that we need to give a vaccine information sheet for everyone who receives any vaccine, including the ones we are talking about today. So another sick canine here, we're going to move on to talking about pneumonia. So again, here are some rates for pneumococcal vaccines gathered by the Healthy People 2020 campaign. And again, they run about the same as the flu vaccine, and the goal being 90% for them. High-risk adults, which is really a different category because this vaccine is routine for 65 and older, but it is in the high-risk population really includes people with heart disease. This can be adult-acquired or congenital heart disease, people with asthma, especially those that are receiving oral corticosteroids, people with cochlear implants for severe hearing loss, people with sickle cell hemoglobinopathies, people that have lost their spleen from an accident, or people with renal failure, and certainly people with neoplasms, and people with organ transplants. So that population, we really need to be zeroing in on alerting ourselves as to who they are and making sure that when they are there, we're aware of it and we don't miss the opportunity to present them with the opportunity to have a pneumococcal vaccine. So this bacteria, which has certainly been around probably longer than humans, and it has both an invasive and non-invasive type of illness. The invasive, which is blood-borne bacteremia and meningitis, which we used to see quite a bit more when I was in training in the 80s, and with meningitis especially. The non-invasive, which includes pneumonia and acute otitis media. So there's been a tremendous decrease in mortality and hospitalization, as you can see on this, with the introduction of this vaccine. So now we have, within the last several years, we have had two adult versions of the pneumococcal vaccine. So we've always given children a Prevnar, which made a big difference, as I said before, in terms of illnesses like meningitis and pneumonia and ear infections. But now we're able to give a polysaccharide, a conjugate-based vaccine to adults. And that, in terms of the trade name for that is the Prevnar, and the current one is the Prevnar 13. So the previous polysaccharide, the PPSV 23-valent vaccine, really induced a B-cell-dependent antibody-producing kind of immunity, which was quite effective against invasive disease, not as much against pneumonia. And now the conjugate, so a conjugate, when you put that onto some antigen, it stimulates the immune system to produce an even greater response. And in this case, it includes the T-cell immunity, which gives a broader scope of immunity and more memory. And this is also more effective against what you call the mucosal or non-invasive kind, which would be pneumonia and otitis media. And if you look at the time when PCV13 came in 2010, which covered a few more of the serotypes of pneumococcus, you see a dramatic decrease in the amount of, especially in children and adults, of pneumonia and other middle ear infections. And here you can see the difference in the coverage of the vaccine and how effective the PCV13 was over the 7 in the different age groups and the pneumococcal polysaccharide in covering the invasive version of this disease in all the age groups. There really is, as I've alluded to before, no arguing with the efficacy of the pneumococcal vaccine. This has been evolved from the 7-valent Prevnar PCV7 to the PCV13, which was a great improvement. And you can really tell when something works when resistance to an antibiotic goes down. Because resistance to antibiotics happens when the antibiotics can see, when the bug can get hit by antibiotics on a regular basis. And if you're preventing illness and you don't even have to utilize the antibiotics, you are really resisting worsening of resistance. And in this case, there has been even a decrease in the resistance of penicillin to the strep pneumonia bacteria, which is something you rarely see. So here, this might be sort of the crux or some of the information that's really hard and fast protective information that people like to review when they talk about pneumococcal vaccine. So there's some scenarios here that we can go over. So the first one is you have had no history or indication to have a pneumococcal vaccine before you turn 65. So today's your birthday, you are 65, and you are going to go to your healthcare provider and you are going to receive a Prevnar 13. And then 1 year from now, because they have an excellent alert system in their record, they will see you and they'll say, I see it's been a year since your Prevnar 13, and we would like to give you your polysaccharide vaccine at this time, and that's how you would do that. If someone received, because they had diabetes or some other chronic illness, the pneumococcal vaccine before they were 65, and that would always be the polysaccharide version of that. Then when you reach 65, you receive the Prevnar. It needs to have been at least 1 year since that polysaccharide vaccine. So if you were 64 and a half when you were diagnosed with diabetes, and then you turn 65 today, I would say to you, in 6 months' time, I'm going to be able to give you your Prevnar. And then after that, I still want to be able to give you the pneumococcal polysaccharide, but it needs to be at least a year after the Prevnar, and it needs to be at least 5 years after that. So half a year ago, I gave you the Prevnar, I gave you the polysaccharide because you were diabetic. 6 months from now, when you're 65 and a half, I'm going to give you your Prevnar because it's been a year. But I'm going to wait until you're 69 and a half, which is 5 years after that 64-and-a-half-year-old polysaccharide virus, to finish off your vaccine for them. And then that's going to be it, even though everyone always feels. There's some memo I didn't receive about getting a pneumococcal vaccine every 5 years, but people seem to be feeling like they should have one. But this is not the case for that. If someone was older than 65 and they showed up with you as a new patient and they were 66 and you had no information that they received their vaccine at age 65, you would just give them one Prevnar. If you're someone in the high-risk category, so the first is some long-term conditions, you would at that time, and those include chronic disease, diabetes, alcoholism, you would just give your Prevnar 23. If you have a situation where, let's take the second one, where say you were in an accident and your spleen burst and it was emergently removed surgically, and then right at that time you would receive your Prevnar, and then in 8 weeks' time you would get a polysaccharide, and then 5 years from then, and people really need to know this if they're moving around with providers, they need to receive another polysaccharide. That's the case when it's nice to have a person have their own vaccine record with them. Okay, if you just had a CSF leak or cochlear implant, you would get that immediate at the time of that condition or that procedure. You would get your Prevnar, and then 8 weeks later you would get your polysaccharide, and that would be the end of the story. So all of these ADT in the 1964 would then move up into the middle category of the 65 and older once they reach 65. So moving on to shingles. So here's a depiction of shingles, which lets you know that shingles really is a reactivation of a virus that lives in our nerve root. That little blue bulb there is our nerve root at that particular level, in this case in someone's thoracic spine, and it is being expressed at the level of the skin, the dermatome for that level of nerve. So here you can see the original on the right. You can see someone that has chickenpox, which most adults over the age of 40 have had a case of chickenpox, whether they realize it or not. You can always check a vaccine, a virus titer for that. So that's the primary infection, and chickenpox is one of those viruses that is never completely eradicated, and at some point in someone's life, they may, people, if they have some stress, there may be some imperceptible decrease in their immune strength, they will have a reactivation, and it's unclear to me why, but at some level along their spine, from the top to the bottom, they will have an expression of it in the way of shingles. And people sometimes get confused because it's called herpes zoster, and to me that is because it comes from the general family we call herpetibiridae. So cytomegalovirus, herpes, Epstein-Barr, varicella are all herpes type viruses, and that's where the zoster, chickenpox, herpes term gets put in there. But people will confuse it with the other herpes simplex virus causing cold sores or genital herpes. So the symptoms of this really start out with something that is not visible, and because it's coming along a nerve, it really has a neuropathic feeling, like someone might have with a diabetic neuropathy. They have a burning, throbbing, searing, stabbing kind of pain, which usually appears days before, and then they will come out with a rash, and it may look kind of red and raised, and it often looks like a vesicle. Some people historically called it a teardrop on a rose petal, so it's a little clear vesicle on a pink face. But it's in a group. It's always in a group. And it can have some systemic symptoms as shown here. The real problem with this condition, besides people having the original symptomatology, which it will include, 10 to 14 days of some uncomfortable time, is that people can have what they call post-herpetic neuralgia. So that is after, say, 2 weeks after, and you no longer have any kind of symptoms, and your rash is really down to some very slightly darker skin than you have around it. This post-herpetic neuralgia, which is the nerve-based pain that continues on and on. The more important version of herpes zoster is the one that involves your eye. It occurs in about 15% of cases. what we were always taught is that if you see someone with lesions, skin lesions that are on the tip of the nose, you have seen someone who's going to have high complications. The ophthalmic division of the trigeminal nerve that innervates your face also innervates your cornea and your tip of your nose. So if you see that, you not only have to treat the patient with the antiviral, you need to have an emergent consultation with the ophthalmologist who needs to use some steroid eye drops. If untreated, that can lead to permanent visual changes. Other complications, which we don't think about so much and are quite rare for herpes, are really CNS ones that are mentioned here involving your brain or spinal cord. But just things to kind of keep in mind. Again, here's the postherpetic neuralgia, and it's defined as pain that lasts over 30 days, can be up to a third of the cases. It's extremely bothersome. You wind up having to use some neuropathic medications like gabapentin, duloxetine, pregabalin, things like that can be very disruptive to your daily routine. Vaccines. For this, there are two vaccines, so I'm going to use the trade name a couple of times here. Zostavax is the live vaccine, which we have had since 2006, and it is a single-dose sub-Q vaccine, and the recombinant, which came out this year, Shingles, which is an intramuscular given once and repeated in 2 to 6 months. And it's some differences in storage, not much. The freezer was for the vaccine for the live, and just refrigeration for the recombinant and the diluent that you use for that. The side effects, because the Zostavax is live, very rarely it could include a serious and life-threatening, really related to the virus illness itself. The Shingles, which is more common, and can be bothersome and even get in the way of your routine for a day or two, but it's really a local reaction. So the recommendations are pretty clear that people should receive the recombinant vaccine. Starting at age 50, they should receive it if they have already received the live vaccine. You should wait at least 2 months. I don't think anyone or many people are getting the previous live vaccine, but if they did, you'd have to wait 2 months until you had the recombinant one. And most importantly, even if you've had the shingles, with the previous vaccine and this current one, you should have the vaccine, the recombinant vaccine given to you. You have a chance of having the illness again. And here you can see when you have either the single dose from the live vaccine previously, or we have a few years of some of the recombinant, the efficacy is clearly much greater for the more recent recombinant vaccine, and it seems to stay longer for several years after that 2-dose vaccine than it does for the single-dose subcutaneous live vaccine. So I think it's pretty much a clear case of using the new recombinant vaccine. Key takeaways, I wouldn't say there's much takeaways of what we talked about so far, but really what I think, besides maybe a fact or two that was useful so far, was ways that we can innovate, use some different workflows to try and improve our vaccination rates. These are some reasons why we have low vaccination rates, based on the provider, not having a system that's ready to give it, not being educated enough themselves, the patients who don't have clear information about it, and the systems which we can do less about. I could mention the systems right now. I mean, there's a shortage. GlaxoSmithKline has recognized the shortage. They're trying to prioritize the U.S. in terms of supplies of their vaccine called Shingles, and they hope that there will be no delays by 2019. But there are some delays because they're giving just limited supplies with each shipment. The insurance we can mention in a minute. So how can we improve our vaccination rate? I think standing orders are really important. One of the resources is an example of a standing order. We have a standing order where I work at Coastal Hillside. You need to educate and empower the appropriate staff to give vaccines. I think reminder systems are very important. I think of reminder systems on the patient level, that should be in there through pre-visit planning or through alerts that have already been placed in the chart. When I open the visit and the chief complaint says review vaccines, I will not forget that because there's a lot of other things that are in there that I'm supposed to remember. I think making sure the conversation happens when the person is brought in and being worked up to put in the vaccine, put in for the visit. Documenting is really important. We even ask people in the non-influenza part of the year about their vaccine because we want to make sure if they got it, we document it in their vaccine rate. So I knew that they got it. And we actually are, thinking about our quality improvement measures that we have with our ACO and our other health plan contracts. We want credit for what we've done. We have a QI initiative for this. We have a bulletin board where we posted. For last flu, we're at 90% flu vaccines for appropriate people. And for our over 65 population, we're at 87% for the Pneumococcal Vaccine. And we post that, and we reward the staff for that kind of performance. Improved access has something to do with insurance coverage. It is, covered by most commercial insurers. I received an email because I spend a very little part of my week here at the CMS QIO from a colleague of mine who said, I see you're giving a talk on and Dr. Robinson gave one recently on Shingles, and he said it's very odd that you are giving a talk to CMS and CMS is not paying for it. So the Part A and Part B certainly don't, and the Part D, depending on the type of Part D, may cover it or not. And people even have the option, if they want to change their Part D at the re-upping period each year to see if it's worth including that in their Part D coverage. Vaccine registries, to me, are really helpful. Here in Rhode Island, we have something called KISNet, which I use almost on a daily basis as a family doctor. To my knowledge, there is not a reliable adult vaccine registry, which would be very useful. I don't want to overstate the degree to which people listen to their providers versus other people, but this is some data that says that they do, and I will tell you that if I have a chat with someone who has already indicated on the vaccine sheet when I have them in a room that they didn't want to receive the vaccine, and I have kind of delved into their reasons why or their fears, I often come out I wind up sending an instant message back to my buddy saying, would you please bring the flu vaccine into room 8? I think having that strong relationship with your patients really goes a long way in that. And also, as I mentioned, we are involved, as many of you are, in other reporting quality measure programs, and these also satisfy, there are measures in those programs that are satisfied by vaccines. Population management, as I mentioned before, we will run a report of people who have not had vaccine, and if they do not have a visit, we will call them and ask them to come in just for a quick nurse visit to receive the vaccine. And that is the kind of difference that brings us up from, say, 75% to a 90% on a flu vaccine. That's sort of population management, chasing down people who haven't had it, who have it somewhere else, and they don't have the documentation. So we're finally to the summary here, and we have a long way to go in terms of vaccine rates. There certainly are effective vaccines, and 2 of them are covered by insurance. And I think that Medicare will come around to covering the Shingles. That is my hope. And that, most importantly, we as practitioners and part of the system of healthcare delivery, no matter what the setting, need to constantly innovate so that we can improve our performance regarding vaccines. Here's the resources that have the standing orders, the BIS sheets, the recommendations, which I think we should have handy every day when we're seeing patients, and the adverse events report system. So, great. So I guess we can move on to we have about 12 minutes left, so we did start a little bit late, but I want to respect people's hour if they have to get back to something at 1 p.m. Here's a question: do you think vaccinating patients in the hospital for the pneumococcal vaccine is necessary, especially since many are likely lost to follow-up for the appropriate follow-up vaccine a year later? So I do think it's worth it. We do not, as primary care physicians, don't spend time. The only place I go now is the newborn nursery, but I don't go in the hospital to help discharge my patients anymore. I believe that is a good thing to do, and the key there in your question that jumps out to me is the communication between the hospital and the primary care office. So we really worked hard on that, just like we worked hard on the communication between the pharmacy, where many people receive vaccines now, and communication from them to our primary care practice is key, or we would miss a lot of vaccines. And with the hospital also, I think with the increased communication, we have a very strong communication with a couple of hospitals that we work around with. So I actually receive a message inside my electronic health record that has happened, and sometimes the transition of care person will actually document the vaccine in there. So I think whatever can be done for that is worth it. Is that the next one? Okay. I'm going to try to look at these in order and get at the ones that. Is there a way to get audio through the computer? Okay. Can long-term care facilities mandate that staff wear masks during flu season if they didn't get the flu shot? Is this a good idea? That staff wear a mask. I'm all for that. I think that got started. One of the doctors that started the practice I have been in for almost 20 years, Michael Fine, who was the health director, he really was behind the regulation in Rhode Island that if you aren't vaccinated by December 1st, whatever setting you work in, you need to wear a mask. And I think that's really a great compromise. I mean, you're protecting the patient and we're allowing you not to be vaccinated. Okay. So here's a good follow-up question to that. Is there evidence that this is effective? It's really hard to tease out when you're implementing several innovations or regulations which one is the cause and effect that's responsible. So it's hard to know whether wearing the mask made a difference. It's hard for me to imagine, given that the flu and pneumonia, but the flu vaccine is transmitted through the nasal secretions from and lung secretions from coughing and sneezing, that having a mask would not have a difference. But I would have to search for someone who thought they had enough of a controlled situation, or maybe someone that was in a state or a setting that was the main thing that they were doing right now. But that's a good question to look into. In a long-term care, if you have had Prevnar 13 and a year later had the Prevnar 23, when is the next vaccine due, and will this be enough? Yeah. So that is enough. I'm assuming this is someone who received the Prevnar 13 because they were 65 or older, and a year later they were received their polysaccharide 23, and that should be enough. That is not a case where people need an extra vaccine 5 years later, as is the case when people who were high risk and received their polysaccharide before age 65. In long-term care, if there is a resident older than 65 that states they had a pneumococcal vaccine but did not know which one, would we provide them with the Prevnar 13? First, yes, I would agree that if you were unable to obtain the record, then I would give them the Prevnar 13 vaccine. And, I might have to check with an infectious disease expert, but my tendency would be to give them that Prevnar 13 when they are your patient in a long-term care facility, and give them the polysaccharide a year later, because there really is not harm. And I would possibly they didn't receive that, and we don't have any hard information. So, and it's not something where you can check a titer like you can for measles, mumps, rubella, chickenpox. Great. And I think we addressed that. It is certainly okay and recommended for people to have the shingles vaccine after they have already had an episode of shingles. And here's someone offering a comment that county health centers in Pennsylvania offer vaccines at little or no cost for seniors, which is excellent. And so I should pass that along to our Department of Health and see if there are public funds available for that. She's qualifying that state-run health centers at the county level. With the influenza vaccine, there's still not a need to take the temp on the resident prior to administration along with no temp for 72 hours afterwards. To my knowledge, if someone does not have a fever and pretty significant illness, then I see no reason not to give them the influenza vaccine. If they had a fever after the vaccine, it would be up to you whether you wanted to report that as a possible vaccine-related event. Is Medicaid covering the Shingles vaccine? It is not, to my knowledge, Medicare and Medicaid. Asked me to briefly explain the quality improvement you have regarding vaccines. I assume you're talking about my practice at Coastal Hillside Family Medicine. I feel like it's multi-pronged in my practice. I alluded to some of it. There is at the time of the visit a medical assistant who is looking at the vaccine page in the record and asking the patient for flu vaccine when we start, which will be, I believe, around September 15th. The flu season runs October 1st to April 1st. If they have received the flu vaccine, we will then also, as I mentioned, call people who have not had a visit during the flu season to see if they will come in and receive a flu vaccine. We will make it something that we do at every visit. Sometimes we do once a year, depression screening and things. But so that is something that we do with every visit. And then I think having a campaign to vaccinate all of your staff and wear a sticker. Luckily, our staff no one has ever had to wear a mask, and we wear a sticker that I was vaccinated. And like I said, I also post information about last year's severity. And I also make a plea, this is not so much systemic, but I tell people that, without telling them that they're selfish, that it's not about you, but it's about the 4-month-old at your house or the great-grandmother who is 88 at your house. And I tell them, you and I are relatively healthy people and are going to have some bothersome illness that we're going to recover from, but they might not. So you need to think about it as protecting the community. Do I feel we will have a busy flu season? Good question. I don't know. But I'm ready for a busy flu season. I just hope every year that we have a more amenable population to receiving the flu vaccine. Do you think that a child 2 years of age, recurrent ear infections, and low polysaccharide immunity should receive the pneumococcal vaccine? That is a good question, and that is something that I would be asking my pediatric ID fellow about. Because that is just a person who does fall into a category for the polysaccharide pneumococcal vaccine. So I'm told that's all the time we have for questions. Thanks very much, and I hope this was helpful.
Okay, well, thank you all for a great discussion. I have a few last announcements before we end today's call, but I know that Russ wanted to speak to the PFAC slides. If Chris, you could pass the ball to either me or Russ. Chris, are you still there?
Yeah.
Could you just pass the ball to either Russ or myself, Dory, so we can go through the rest of the last couple housekeeping slides?
Dory, we're having a difficult time changing. It's just our technical issues again. But I just wanted to add that for each of our events, we try to encourage people to have their patients participate in their care in some of the decision-making processes within the practices. So if you do not have a PFAC already, I know in each of the New England states there is a PFAC through the QIN-QIO. If you have people that are interested in participating, please have them get in touch. You can go through the Healthcare for New England website, and all the information is there under PFAC. But I wanted to thank everyone, and if there's anyone who had a question that was not answered, we'll continue to answer them in the chat over the next couple of minutes. All right, thank you.
Okay, so when you close out of this webinar, the evaluation will automatically pop up on your computer. You could please fill that out. That would be greatly appreciated. You don't have time to fill out the evaluation right now, or you're currently sharing a computer with someone else, you'll receive an email tomorrow with the link to the evaluation. The PowerPoint presentation is also posted on the website, so you can go and refer to it there as well. And thank you again for attending, and I hope you all have a great rest of your day.
The leader has disconnected. The conference will be terminated in 5 minutes.